Hello and welcome to Noon Conference hosted by Medality. Noon Conference connects the global radiology community through free, live educational webinars that are accessible for all and is an opportunity to learn alongside top radiologists from around the world. You can access the recording of today's conference and previous Noon conferences by creating a free account. Today, we are honored to welcome Dr. David Yousem for a lecture entitled CNS Vasculopathies. Dr. Yousem is a neuroradiologist and professor of radiology at the Johns Hopkins University School of Medicine. He's the author of over 350 scientific papers and several popular books in radiology, and has also served as the president of the ASNR and was awarded the Outstanding Educator Award from the RSNA. We're especially grateful to Dr. Yousem for his support of Medality and for serving as our neuroradiology advisor. At the end of the lecture, please join him in a Q&A session where he will address questions you may have on today's topic. Please remember to use that Q&A feature to submit your questions so we can get to as many as we can before our time is up. With that, we are ready to begin today's lecture. Dr. Yousem, please take it from here.
Thank you very much. Well, happy Thanksgiving week for those of you who celebrate. For all of us, we should always be grateful for all of the blessings in our lives. And I'm certainly thankful for all my opportunities to teach with you, and also the opportunity for 50% off on Black Friday sale for Medality membership. Very good. We were just talking about great sales. So today I'm going to talk to you about imaging of CNS vasculopathies. I changed the topic from CNS vasculitis because I did want to address some of those vascular pathologies that are not necessarily inflammatory, but are very common that we see. With regard to my disclosures, of course, I am a consultant to Medality and a lecturer here, and also receive royalties from Elsevier, and I do medical legal consulting work. So fortunately, the nomenclature for vasculitides was formalized at the 2012 International Chapel Hill Consensus Conference on Vasculitides. And effectively, instead of going with a lot of different infectious, inflammatory, and autoimmune disorders, the way they decided to organize the vasculitides is by the size of the vessel that is involved. So we have large vessel vasculitis, we have medium vessel vasculitis, we have small vessel vasculitis, which are related to the immune complex, and other associated small vessel vasculitides. However, it's also well known that there are a lot of other categories of vasculitides that don't fit well into each of these different classifications. However, when we think about large vessel vasculopathy, not necessarily inflammatory, we must also consider atherosclerosis. In a lot of people's opinion, atherosclerosis is a type of inflammation of the large vessels. In addition to Takayasu's arteritis and giant cell arteritis, which are mentioned in that Chapel Hill consensus, there are a lot of other vasculopathies that affect the large vessels, which I will now cover. So let's start with atherosclerosis. I have been blessed, and I am grateful for the presence of Bruce Wasserman in the Division of Neuroradiology at Johns Hopkins for probably around 20 years before he moved on to the University of Maryland. During that time, Bruce was one of the three most foremost experts in evaluation of the blood vessels for atherosclerosis with high resolution black blood imaging. And some of the work that he did was just monumental in looking at not just the degree of narrowing of the blood vessels that we usually think of with the NASET criteria, but also all of these papers that he wrote regarding the composition of the atherosclerotic plaque. Because we all know that there are a lot of patients who don't have high degree of narrowing that nonetheless flip emboli into the brain and cause strokes. And this was sort of Bruce's passion, for which he worked on, particularly with one of his junior faculty, Ye Kao. So here are some of the black blood images that Bruce produced looking at pre and post contrast plaques in order to characterize the lipid core, the fibrous cap, and calcification, and finally hemorrhage in the wall of a plaque. And what Bruce initially started looking at was the enhancement of the wall of the plaque and the intima for what is called the fibrous cap. And what he initially showed was thinning of the fibrous cap was associated with an increased risk of thrombogenesis and emboli. He moved on to looking at things like the intraplaque hemorrhage. And it turned out that a lot of the fibrous cap, lipid core, and intraplaque hemorrhages worked together to expose the lumen to the intima of the and media of the blood vessel that led to thrombogenesis. So here are some of the additional dark blood imaging that Bruce did with regard to atherosclerotic plaque. Here's an example of the intraplaque hemorrhage that is confirmed by the histopathology. And although he came to the intraplaque hemorrhage after fibrous cap thickening and the lipid core, turned out that hemorrhage in the plaque was a very high risk factor for thrombogenesis and subsequent emboli. Eventually, Bruce moved his work to intracranial atherosclerotic plaques and showed that in intracranial atherosclerotic disease, the plaque enhancement tended to be eccentric and heterogeneous, and often at the bifurcation points of the intracranial blood vessels. And this enhancement could persist for a long period of time with the atherosclerotic disease and was a risk factor for emboli and strokes in that vessel's distribution. Here's another example of three different plaques with different amounts of contrast enhancement associated with it. And he was able to grade the degree of the contrast enhancement and showed that the degree of contrast enhancement of the intracranial atherosclerotic plaque increased the risk of the thrombogenesis and ultimate stroke. When you look at all of these different components, generally in the neck, but also in the intracranial compartment, you see that they may all occur together. You can have a thick, widened wall. You can have the lipid-rich core. You can have ulceration of that vessel, and that can lead to intraplaque hemorrhage. Another example of the thickness of the fibrous cap as seen by the contrast enhancement, as well as the high signal intensity that may be associated with the hemorrhage in the wall of the blood vessel. So this was a very nice article that I thought was important to demonstrate to you, because it was an expert panel looking at consensus opinions about relative risk of stroke associated with atherosclerotic plaque components. And I want to highlight this OR column here, relative risk of stroke if the characteristic is present. And what you see is that the highest risk factor is intraplaque hemorrhage, followed by the necrotic core or the plaque thickness. Calcification, interestingly, is associated with a lower rate of stroke within that vascular distribution. So for all of us who are all concerned about our calcium score on our cardiac CT examination, calcification, because of statins, has been actually a favorable occurrence in a lot of cases of atherosclerotic plaque, at least with regard to the carotid arteries. So it sort of stabilizes the plaque such that it is not at risk for stroke. So again, to emphasize, intraplaque hemorrhage, a very important risk factor for the subsequent stroke risk with atherosclerotic plaque. Lipid-rich core and thickness of the plaque are also important. Obviously, the other thing that we look at when we're looking at the blood vessels in the neck is not just atherosclerotic disease and intraplaque hemorrhage, but wall hemorrhage, which may occur under such circumstances as trauma or fibromuscular dysplasia or other vasculopathies. And here you see a carotid artery which is narrowed and has this bright signal intensity from a wall hemorrhage. This is pretty high up in the neck. This is not at the expected location for the carotid atherosclerosis at the bifurcation. And here is an angiogram showing a similar case with dissection of the carotid artery leading to intracranial stroke. In addition to dissections, we can also have the outpouching of those blood vessels, either associated with a traumatic event or one of these vasculopathies that predisposes to initially dissection and then pseudoaneurysm formation. And we're seeing it here on the MRA and the CTA and the conventional arteriogram with a pseudoaneurysm. I'm going to get back to intracranial black blood imaging for vasculitides, but I do want to emphasize what Bruce taught us all, and that is that remember that the atherosclerotic disease intracranially tends to be eccentric around the blood vessel and more commonly at bifurcations, and you see the contrast enhancement here. Whereas what we're going to see with vasculitides is that it is a more symmetric and diffuse concentric enhancement, and that's going to be our distinguishing feature between atherosclerotic intracranial vascular disease versus the intracranial vasculitides such as PACNS. Here again, you see the nice and smooth and concentric involvement with vasculitides as opposed to the eccentric involvement with atherosclerosis. So let's deviate from atherosclerosis and get back to the classification of the Chapel Hill consensus. And as you see, under large vessel vasculitides, the two that they describe are Takayasu's arteritis and giant cell arteritis. So Takayasu's arteritis, generally in neuroradiology, we're more concerned with the subclavian arteries and the potential hit on the vertebral arteries. And I remember from residency, I had a great case of subclavian steel because of Takayasu's arteritis affecting the subclavian artery proximal to the takeoff of the vertebral artery. But frankly, Takayasu's arteritis is something that we see once, twice, 3 times a year, as opposed to the chest radiologists who may be more commonly seeing it. This is a particular example of a patient who has a pulmonary artery involvement with Takayasu's arteritis, but nonetheless, you can see that involvement and the narrowing in the subclavian artery on the right side over here and on the left side as well. Rarely we will see Takayasu's arteritis affect the carotid arteries. This is an example of that, where you see a focal area of narrowing, actually 2 areas of narrowing in this carotid artery in a patient who had bad disease affecting the right-sided subclavian artery as well. The second of the large vessel vasculitides that was described is the giant cell arteritis. Again, we usually don't see that intracranially. That's more commonly seen around the blood vessels as the takeoff from the aorta, for example, and elsewhere in the body. In this case, the abnormality is the degree of wall thickening that you see around the enhancing lumen on this CTA. And this is more than what one would expect for as far as diffuse involvement. As far as atherosclerosis, of course, we would look at the age of the patient, and this would be uncommon in a younger patient to see this amount of wall thickness of all of the vessels taking off from the aorta. With regard to the intracranial manifestations of something like a giant cell arteritis, remember that we want to look for enhancement and thickening that may be narrowing the lumen, but that is concentric around the blood vessel to distinguish it, as said previously, from the atherosclerotic etiology. Now, the consensus did not talk about other large vessel vasculopathies such as moya-moya disease and some of the other entities I'm about to describe for you. And I think that's because they did not consider them primary arteritis and inflammatory conditions, as opposed to a vasculopathy without necessarily those inflammatory components. However, we see moya-moya a lot more commonly than we see something like giant cell arteritis or Takayasu's arteritis, particularly at Johns Hopkins, in part because of the predisposing factors for moya-moya syndrome, and that includes things like sickle cell disease, that we see a lot of in East Baltimore. So here we have a patient that we are looking at the circle of Lewis vessels, and as we sort of see this petering out of the distal internal carotid arteries bilaterally, and we have that kind of lenticulostriate collateral appearance that people will talk about as a sort of puff of smoke, better seen, for example, on conventional arteriography, but we do see this as well with our CTAs. And you can see that the distal involvement of the internal carotid artery is kind of classic. However, it may extend into the proximal A1 and M1 segments of the anterior cerebral and middle cerebral arteries. Now, we have an expert in our institution, Rafael Tamargo, on moya-moya, and he makes the distinction and really pushes the emphasis here that moya-moya disease is that entity that affects bilateral involvement of the distal carotid arteries in these vessels, and generally is of an idiopathic etiology. When we see a single carotid artery with a puff of smoke that's secondary to sickle cell disease or to radiation vasculopathy or to severe atherosclerosis, that term should be moya-moya syndrome or moya-moya appearance. But the disease, as it is described, should be bilateral involvement and generally of an idiopathic and more common in the Asian population. The other entity that is a large vessel vasculopathy that I should mention is fibromuscular dysplasia. Here we have several examples of different patients from our teaching file with fibromuscular dysplasia, where we have that beaded appearance of widening and narrowing on multiple blood vessels. Here you can see that area of narrowing and widening, and in this case, even a dissection with a pseudoaneurysm of the right distal internal carotid artery. The widening here, the dissection flap on the right side of the distal internal carotid artery, which is also seen here. So fibromuscular dysplasia, we used to have all these different varieties, the medial and intimal and adventitial varieties. Now the nomenclature basically is it focal or multifocal? In other words, is it a single happening in a single vessel, or is it in multiple vessels with multiple changes over the same vessel? So the widening and narrowing, as opposed to a single widening and narrowing, if you will, for the focal versus the multifocal involvement bilateral and in multiple portions of the same vessel. Fibromuscular dysplasia, again, not listed as a vasculitis, but considered a vasculopathy because it's not really inflammatory cells affecting the wall. May manifest intracranially with strokes or with TIAs, with dissections, subarachnoid hemorrhages of the dissected vessels or pseudoaneurysms of the vessel, or there is a higher rate of aneurysms itself in these patients who have fibromuscular dysplasia, such that it may be one of the entities that we do screening for aneurysms intracranially. The carotid arteries are affected more commonly than the vertebral arteries, and bilateral involvement of the carotid artery is seen in 61% of those that are affected. It's usually an extracranial manifestation, so not really central nervous system, if you will, more in the neck, but you may see it in 14% both intracranial and extracranial, and 11% just intracranially. So obviously 25% have intracranial involvement, and that involvement may be narrowings, widenings, aneurysms, dissections intracranially. The risk of stroke in a patient who has fibromuscular dysplasia is around 1 to 5% per year, according to this article. Of course, fibromuscular dysplasia is not just manifested in the central nervous system or in the cerebrocranial or craniocerebral vessels, or cervicocranial vessels in the neck and intracranially. The renal arteries are often affected, even more so than the internal carotid arteries. And the manifestations in the renal arteries is it may be a source of patients' hypertension. You can have involvement of the mesenteric arteries leading to mesenteric ischemia. Mean age 57. 43% of patients with cervicocranial disease have renal disease. Anyway, we see the same sort of manifestation, the string of beads sign, maybe the pseudoaneurysm dilatation of the blood vessel. You can see that on both the conventional arteriogram here, as well as a nicely done CTA showing those vessels. Finally, of those large vessel vasculopathies that may affect the intracranial or the extracranial vessels, I should report on those patients who are affected by radiation. Radiation, while it can lead to a vasculopathy in and of itself, also leads to acceleration of atherosclerotic disease. And this was actually taught to me by my good friend Tae-Sub Chung from South Korea, who was visiting us at the University of Pennsylvania and asked to do a project on looking at the degree of vascular narrowing on pre-radiation and post-radiation carotid arteries to see whether there was a manifestation from the radiation therapy. Normally, we wouldn't expect that much of a difference in the degree of narrowing over the course of, say, 6 months in adult patients. However, when we looked at the pre-radiation and the 6-month post-radiation scan, what we found was here we have a patient who pre-radiation, the grade of narrowing was 0. Post-radiation, you can see that it got into the mild and moderate and severe forms. And so there was this upgrade in the degree of atherosclerotic narrowing or vascular narrowing in the neck in 56% of the vessels that were within the radiation portal. And the average grade upgrade was 1.4 from like 1 to effectively 2.4, from 3 going up to the 5 or 4 range. So you see that here. Here's the vessel pre-radiation. Here's the vessel post-radiation, and there were areas of narrowing. So radiation vasculopathy, both intracranially, where you may see narrowing, and as I mentioned, it may be the source of Moyamoya syndrome, not disease, but syndrome, affecting the blood vessels. And that may be unilateral or bilateral, frankly. A lot of times we see radiated cellas for pituitary adenomas that could not be completely resected, or meningiomas that are being treated. And you may see bilateral cavernous carotid artery or supraclinoid internal carotid artery narrowing secondary to the radiation. That may occur also with nasopharyngeal carcinoma, which again may be one side if the fossa rosemuller on the left side is involved, for example. Another entity that will look like a large vessel vasculopathy is RCVS, reversible cerebral vasoconstriction syndrome. This is a syndrome that is characterized by the thunderclap, abrupt onset headache, again, worst headache of life. The vasoconstriction is temporary. It usually does resolve over the course of weeks to months. And the risk factors for RCVS overlap PRES. And in fact, sometimes you will have white matter changes in the brain on MRI that simulate PRES with patients who have RCVS. However, they also will show vasoconstriction, large vessel narrowing vasoconstriction in the patients. Unfortunately, that vasoconstriction may not be present on the first day of presentation with the thunderclap headache. It actually may develop over the course of 3 or 4 days that you see vasoconstriction. So it's almost, if you will, it's almost like subarachnoid hemorrhage, where we don't see that vasoconstriction initially on the original subarachnoid hemorrhage from, say, an aneurysm, but over the course of days, it gets worse. And you can see just how narrowed that may be in the MCAs, for example, or the A1 segment on this patient, and also on some of these examples. Note that with RCVS, there may be some element of subarachnoid hemorrhage that is associated with the RCVS, seen here as the lack of suppression of the CSF on the FLAIR image. Another large vessel entity that I should mention is amyloid angiopathy. Again, not necessarily a vasculitis. This is usually seen in older patients. I won't say elderly. I'm not sure what that is anymore since I'm now Medicare eligible. Multiple cortical hemorrhages, different ages, sometimes leading to subarachnoid hemorrhage, sometimes leading to subdural hematomas, and sometimes leading to hemosiderosis or siderosis of the pia arachnoid. Differential diagnosis is often malignant hypertension, vascular malformations, multiple emboli. Obviously, we're going to look into the EMR if the patient is not hypertensive, never been treated for hypertension, et cetera. Then we're going to more likely float the idea that this may be amyloid angiopathy. Here's a patient with a lobar hemorrhage on MRI as well as CT scan, negative with the arteriogram, but a vasculopathy, amyloid angiopathy. It's important to do your gradient echo, or in most cases now, people now have susceptibility weighted imaging because that will show the multiple hemorrhages that can occur in a patient with amyloid angiopathy. In addition to the parenchymal or subcortical white matter hemorrhages, what we see here is that hemorrhage that has been implanted or deposited in the pia arachnoid such that we have siderosis or hemosiderosis for those of us who like multiple syllabic words. So both hemorrhage in the periphery and the cortex, as well as hemorrhage leaking into and depositing in the pia arachnoid, amyloid angiopathy. That occurs in about 30% of cases, the hemosiderosis. There is the Boston criteria 2.0 for cerebral amyloid angiopathy. I'm going to let you read this on your own or look it up. Suffice it to say that they do include for probable CAA MRI scanning findings of intracerebral hemorrhage, microbleed, superficial siderosis, and subarachnoid hemorrhage. So we'll move ahead. Another example, this is the same patient I showed previously with that lobar hemorrhage, but if you look elsewhere, you see multiple other little micro hemorrhages in the brain scattered about, and that's pretty typical for amyloid angiopathy. So it's about time to move from the large vessels, of which we took about 28 minutes, and move to the medium vessel vasculitides. And the two that are mentioned in the Chapel Hill consensus are polyarteritis nodosa and Kawasaki disease. Polyarteritis nodosa is a necrotizing vasculitis, medium as well as some overlap to small vessels that may be associated with kidney problems as well. In the central nervous system, which is affected 1/3 of the time, you can have aneurysms, hemorrhage, thrombosis. However, the vasa novorum of the peripheral nervous system is a more common manifestation than in the central nervous system. So it may lead to a peripheral neuropathy. So in addition to all those other entities, usually most commonly diabetes or for peripheral neuropathy, polyarteritis nodosa is one of those etiologies for peripheral nervous system involvement. And interestingly, polyarteritis nodosa may affect spinal vessels. In fact, I have a good case thereof. So aneurysms in the brain and stenoses. This was a patient who had aneurysm of the vertebral artery with a small pseudoaneurysm. And you could see that thrombosis of that aneurysm on the fat-suppressed T1 weighted scan. So by applying the fat suppression, we eliminate any, of the atherosclerotic plaque components being bright. And what we see as the bright signal is usually the hemorrhage in the wall or hemorrhage in the thrombosed aneurysm. Occasionally, you will have that with slow flow and the artifact of slow flow. Here is the example of a patient who had aneurysms as well as vascular narrowings. You could see the left T9, the right T7 vessel in the spinal vessels with involvement of polyarteritis nodosa. Here, the vertebral artery with areas of multiple narrowings as well as uh, dilatation. Now, this might look like fibromuscular dysplasia. We'd give contrast FMD by and large for uh, for black blood imaging. FMD not usually enhancing polyarteritis nodosa would show that concentric ring enhancement around the blood vessel. Okay, one of the other main vasculopathies that we see in neuroradiology is the primary angiitis of the central nervous system, or PACNS. They call it here primary central nervous system vasculitis. So that's listed in the variable vessel vasculitis category for the consensus. So not necessarily one that they described when they're looking at the full body picture of vasculitides. But primary angiitis of the CNS, and you'll see it as PACNS, has specific criteria, which include, confirmation, obviously, on a tissue biopsy, but high probability is with on angiograms or with abnormal findings on the MRI or a CSF profile consistent with it. This is distinguishable from the RCVS by the symptomatology not usually presenting with a thunderclap headache, for example, and also the vascular findings that we'll see momentarily on our black blood imaging. So, primary angiitis of the central nervous system, as defined by the Archives of Neurology, this is showing the difference between PACNS and RCVS. Again, chronically progressive versus acute severe thunderclap headache. The neurologic symptoms occur with the headache, whereas with PACNS, you may have, strokes basically that are occurring and causing the neurologic findings. The CSF showing the leukocytosis, the vasculitis in the CSF for PACNS, not seen in the RCVS patient. So, what do we see with primary angiitis of the central nervous system? We usually see strokes, often in the subcortical white matter or the deep gray matter, not as much cortical involvement. They're in multiple vascular distributions, but not out to the periphery. So, sometimes we see things in multiple vascular distributions and we think, maybe this is cardioembolic disease. Those are usually out in the periphery and more cortical, whereas the PACNS is more in the subcortical white matter. For example, they usually are not enhancing with thromboembolic disease, but may enhance in 1/3 and meningeal enhancement with PACNS. And that's very useful because that location of the meningeal enhancement may lead to the targeted biopsy of the meninges to make the diagnosis when the angiogram and the MRI are not suggestive. Because sometimes they may have normal angiograms and normal MRI scans. So here you can see a very large differential diagnosis of PACNS. I won't go through it, but anything that basically can cause repetitive multiple neurologic episodes. So here again is where our vascular imaging of the intracranial vessels is very useful, both for the MRAs as well as the black blood imaging. Here, for example, we see the patient. Let's just look at this right posterior cerebral artery where we see areas of vascular narrowing amidst the normal caliber of the blood vessel, both in the longitudinal section of the blood vessel as well as, in this case, a focal area at the bifurcation. When we look at our post-gadolinium enhanced MRA, we see enhancement on both sides of the posterior cerebral artery, which corresponds to this perimesencephalic portion of the blood vessel and its more distal portion over here. This is probably the most flagrant example of an arteritis that I had seen and was loaned to me by Bruce and Ye Cao. And what you see here is just the remarkable enhancement of the middle cerebral artery beyond the bifurcation on both sides of the blood vessel bilaterally and just incredibly thick. And I will admit that on this vessel, it looks like it's a little bit eccentric, but you have lots of vessels where you see it on both sides of the vessels and associated with the narrowing. Another example, sometimes the manifestation looks like it's parenchymal with the blood vessel central within that parenchymal abnormality. And I give this example. Here's a small flow void with enhancement around it, but you can see that there's actually other little black dots here. And if we were doing 7 Tesla imaging, I imagine this would really be quite extraordinary. But this patient who has primary angiitis of the central nervous system had some parenchymal enhancement around these vascular narrowings and enhancement, as well as the meningeal enhancement, which I mentioned can be used to target for biopsy. Okay, we're moving from the medium vessel vasculitides to our small vessel vasculitides. And some of these small vessel vasculitides we don't see very commonly in neuroradiology or in the central nervous system, and frankly, at Johns Hopkins. So some of these I'm going to be showing images from the literature. So this is IgA vasculitis. That's the new name that has been applied, previously Henoch-Schönlein disease. And the CNS manifestations of IgA vasculitis are more commonly revolving around hypertensive encephalopathy, such that it is in the differential diagnosis with PRESS, as well as some of those cases of RCVS that are also associated with hypertension that may be manifesting white matter disease. So you can see here, this is before and after treatment. And you see the high signal intensity bilaterally in the cerebellar hemispheres, as well as in the parietal occipital lobes. And that, with treatment with steroids, for example, can improve dramatically. You may also find hemorrhages in the brain associated with IgA vasculitis. With regard to what was previously called Wegener's granulomatosis, but now we refer to it as GPA, granulomatosis with polyangiitis, so GPA. This is, again, generally considered small to medium vessel vascularity that is associated with anti-neutrophil cytoplasmic antibodies. So you may have seen on that initial discussion of the nomenclature of vasculitides, we were talking about ANCA and non-ANCA vasculitides. The ANCA refers to this anti-neutrophil cytoplasmic antibodies, which can be detected, that are associated with the myeloperoxidase system. In this example, we have necrotizing granulomas. And frankly, most of the time when I'm thinking about GPA, I'm usually thinking about manifestations in the paranasal sinuses and in the orbits with inflammatory conditions, with inflammatory disease, often with associated nasal septal perforations, for example, and paranasal sinus disease with bony erosions. So nonetheless, the central nervous system is involved in about 7 to 11% of cases with GPA, more commonly seen in the body manifestations, including in the kidneys and in the chest. So there is another entity which is called eosinophilic granulomatosis with polyangiitis. It's similar to GPA, but the difference is that the white blood cell, the blood cell that's associated with it, is an eosinophil as opposed to the neutrophil that is classic with the GPA. So here is my vision of GPA as a neuroradiologist. That is sinonasal disease associated with nasal septal perforation, bony erosion, and potentially involvement of the orbits with this diffuse inflammatory process that encases the extraocular muscles and the extraconal space, and generally low signal intensity on T2 weighted images of the orbits as well as the sinonasal cavity. However, as I mentioned, the meningeal involvement is one of the more common of the central nervous system involvement, more so than what we see with regard to the vasculitis. But nonetheless, this patient was one that did show manifestations in the middle cerebral artery distribution of the vasculitis. Sometimes with both GPA, Wegener's, as well as sarcoidosis, we see these little microhemorrhages, particularly around these small vessels at the periphery of the brain. And that is another of the manifestations of GPA. You see all this little tiny enhancement of the small vessels, similar to what we were seeing previously in the patients who had primary angiitis of the central nervous system. So this kind of spotty enhancement, which may be associated with the wall enhancement of a vasculitis, would be another picture that you should put in your mind's eye with regard to granulomatosis with polyangiitis. So I mentioned the other entity that's associated because it has eosinophils as opposed to neutrophils associated with it. And this is the eosinophilic granulomatosis polyangiitis. The American College of Rheumatology says you have to have 4 or more of these manifestations. And it really kind of looks almost like allergic fungal sinusitis from the standpoint of asthma, blood eosinophilia, involvement of the paranasal sinuses, sometimes pulmonary infiltrates, peripheral neuropathy, and extravascular eosinophilic infiltration. Central nervous system involvement, relatively uncommon with regard to PRES, intracranial hemorrhage, vasculitis. Here is a case from the literature of a patient showing the sinonasal involvement with the eosinophilic granulomatosis, as well as white matter disease and areas of vascular narrowing that you can see. Again, the white matter disease may look like PRES. Here's something a little bit more anterior. This is more the posterior reversible encephalopathy syndrome example with eosinophilic granulomatosis polyangiitis. So let's look at a few of these other entities. We've dealt with the kind of the non-ANCA ones and the ANCA-associated small vessel vasculitides, including GPA and eosinophilic granulomatosis with polyangiitis, formerly known as Churg-Strauss disease. Let's look at some of these other entities that we may see in neuroradiology. So I mentioned neurosarcoidosis. By and large, most of the time when we're looking at neurosarcoidosis, we're looking at meningeal pathology or enhancement along the cranial nerves, and not so much the vascular manifestations of sarcoidosis. However, you can see those vascular manifestations. It used to be that we thought this was more on the venous side, and you can have venous infarctions and peripheral bleeding from venous infarctions. However, you may manifest, as you see here in the middle cerebral arteries, an arterial variety of neurosarcoidosis, vascular epithelial granulomas of perforating arteries and veins, often with manifesting as stroke, in addition to those meningeal and cranial nerve pathologies that we see with neurosarcoidosis. This is another entity where clearly you want to look at the paranasal sinuses and the orbits because you may see the sarcoidosis involvement of that as well. What about lupus? Well, they didn't mention lupus vasculitis. So a lot of times lupus vasculitis or vasculopathy is more considered a thrombotic entity rather than an inflammatory disease. And that's because of the antiphospholipid antibodies, the lupus anticoagulant associated serology that may predispose one to a stroke. So most of the time, we're not really seeing vascular enhancement with lupus. What we're seeing is a patient who has multiple strokes, unknown source, doesn't really have a coagulopathy that is manifested by, the typical complement cycle or coagulation cycle, but is associated with the lupus antiphospholipid antibody. Tuberculous angiitis, well known, manifested secondary to the meningitis that affects the basilar cisterns, and therefore those perforating arteries, particularly lenticulostriates or thalamic perforating vessels, etc., may have central sort of stroke involvement. Here's a patient who has the meningitis with TB showing communicating hydrocephalus with gumming up of the subarachnoid space and the the CSF production and resorption, but also showing the enhancement all around the circle of Willis as well as in the interpeduncular cistern by virtue of that vasculitis. And therefore, what we usually see are the the M1 segment and the lenticular striate involvement, either with the vascular enhancement or the strokes that are seen in the basal ganglia, brainstem, thalamus, etc. And here you can see a pretty dramatic one. This is actually a flare post-contrast scan. So patient has hydrocephalus secondary to the arachnoid villi being gummed up with TB and with central strokes here around the basal ganglia, maybe even the hypothalamus. With respect to the clinical manifestations, they may be motor deficits more so related to basal ganglia involvement rather than, for example, the motor cortex, confusion, headaches, coma, seizures, etc. Strokes in 50%, hydrocephalus 40%, meningitis. As you see here, look at this Sylvian fissure with the meningeal enhancement, and obviously all the blood vessels within the subarachnoid space of the Sylvian fissure exposed to that inflammatory disease and potentially manifesting ischemic injury, usually the MCA. Another of the infectious inflammatory vasculopathies includes varicella zoster vasculitis. Again, more commonly lenticular striate, M1 disease. This one, unfortunately, having a large middle cerebral artery distribution infarction, took out portions of the A1 segment on this. Notice that the distal internal carotid artery here is narrowed. The proximal M1 is narrowed. We don't have a good puff of smoke to say that this is moyamoya, but this could be a manifestation that could lead to moyamoya disease. And then with the contrast enhanced black blood imaging, you see the enhancement on both sides of the vascular wall, a little bit eccentric, I give you, and also in the meninges. Ankylosing spondylitis, generally we don't see intracranial manifestations of that vasculopathy, but we may see the involvement of the aorta manifesting in the proximal branches that can lead to strokes associated with the vascular involvement. And usually that's more of a distal aorta disease than a central nervous system disease. Inflammatory bowel disease can lead to a vasculitis, and that also can lead to these areas of narrowing within, in this case, a pretty good segment of the pericallosal artery, as well as the callosal marginal artery, with areas of vascular narrowing and even cutoff of some of those blood vessels. So this is Crohn's disease, for example. All those other inflammatory bowel disease, ulcerative colitis, may manifest with a central nervous system vasculitis. It's unusual, but another of the things to consider. Lymphoma may also lead to a vasculitis, and this may be a vasculitis associated with either the treatment of the lymphoma itself, or sometimes, remember, we do have intravascular lymphoma, which can lead to presentation with even strokes, even though it's a lymphoma final diagnosis. And once again, you may see the enhancement of the vascular wall associated with either treatment of lymphoma with some of the agents such as L-asparaginase that can do that, or the lymphoma itself. In this case, note also that we have really nice manifestation of PL enhancement of the periphery here in the parietal occipital lobe bilaterally, as well as the vascular contrast enhancement. All other autoimmune vasculitis, this one was not well characterized. You can see that this may progress pretty severely from 2014 to 2016 and have this ill-defined enhancement that when you drill down on it more closely, you can see is also associated with the vascular wall. I mentioned L-asparaginase, but a lot of the other medications that are given for things like lymphoma or leukemia may lead to a vasculitis. And as you can see here, this is pretty dramatic in the right middle cerebral artery beyond the bifurcation, as well as in the M1 segment and the A1 segments. After the asparaginase was discontinued, they repeated the MRA and look how well it all healed and returned to a more normal appearance. So L-asparaginase may be a thrombotic effect, but it may also, as with other medications used in leukemia and lymphoma, may actually lead to a vasculopathy that may manifest by areas of narrowing intracranially. Neurofibromatosis, remember that neurofibromatosis may be associated with internal carotid artery aplasia or hypoplasia. And that actually is one of the other manifestations or etiologies for moya-moya syndrome affecting a unilateral internal carotid artery. Here you see the normal carotid artery on the left side, the absence of the carotid artery on the right side. And the giveaway here is that the patient also has sphenoid wing dysplasia, which is one of the other manifestations of NF1, and we don't really see a blood vessel here. This patient may develop moya-moya as well. Finally, the last entity I want to mention is the amyloid beta-related angiitis. This is a form of cerebral amyloid angiopathy, but with an autoimmune inflammatory component that targets the amyloid in the blood vessel wall. Remember, I initially talked about amyloid angiopathy as a vasculopathy without the vasculitis. However, there is a form of this that may be an inflammatory vasculitis, the amyloid beta-related angiitis. It's one of the manifestations that may be fatal if not diagnosed, because it's usually late diagnosis. People don't understand that there is this component of inflammation that has to be treated with the anti-inflammatory drugs, including steroids, for example, immunosuppression. And in addition to the cerebral amyloid angiopathy findings and with strokes edema, you will see a more common leptomeningeal enhancement, which may be the tip-off that this is not your run-of-the-mill CAA. This is the amyloid beta-related angiitis. And here's a example from the AJNR with multiple small strokes, as well as the meningeal enhancement that was associated with the occult amyloid beta related angiitis of amyloid angiopathy. So I'll end with this final slide. We've covered a lot of these entities, some of which we would characterize as vasculitis. Some of these we characterize as a vasculopathy without necessarily a dominant inflammatory component that would define a vasculitis. But I think that we've gotten a nice overview of a relatively obscure topic, and I hope you learned something from it. So with that, I am going to stop my share, show my happy face, and go to the question and answer. So one of the persons asked, what exactly is black blood imaging? So black blood imaging is a technique in which the flow of the blood is dark, and we look at it on T2 weighted, T1 weighted, and postgad T1 weighted to look at the vessel wall. So it's vessel wall imaging. You may see VWI or, this is the idea that stenosis and degree of narrowing is not the wherewithal of risk factors for stroke. That at least in the neck, for example, it's not just the degree of narrowing by NASAT or ECAS or whatever criteria that you may use. It's also the quality and characteristic of the plaque, which may be predisposing to stroke. So if you look at any of Bruce Wasserman's papers, including techniques, you'll see how it is that you have to do multiple suppression pulses, back and forth inversion pulses, in order to eliminate that flow ghosting artifact or the flow artifacts in order to get it as a black blood vessel to see the wall that much better. At what time after contrast enhancement do you scan the patient in order to best depict vessel wall enhancement? We are um, we are doing 2 sequences after the contrast enhancement, but we are not delaying the the imaging after the injection. How do you differentiate between intraplaque hemorrhage versus thrombosis? So with intraplaque hemorrhage, the location of that blood product is different. Obviously, it's in the plaque outside the lumen of the vessel. With luminal thrombosis, you're not seeing flow in most cases. It can be a non-occlusive thrombus. But this is, again, much better visualized on the black blood imaging where you see the lumen as the black area and the wall of the vessel, often on contrast enhancement because of the fibrous cap, you can actually see the enhancing wall of the intima. So that's how we do that. What is your experience with vessel wall imaging and the stenoses commonly seen in press? So I will admit that we don't usually do vessel wall imaging in patients with press. It's known to be a type of vasculopathy, but I don't have experience with stenoses in press. We often do not give contrast enhancement in the press cases as well, so we might not see that because we're not doing an enhanced scan. With press, you may see contrast enhancement in the parenchyma that occurs in about 10 to 15% of patients who have press, where you may see cortical or juxtacortical enhancement. 10 to 15% of patients with press will also have DWI positive ischemic injuries that are basically strokes. Okay, next question. In your experience, what is the sensitivity and specificity of black blood MRI in the diagnosis of vasculitis? It is, I think, very much entity dependent. At Hopkins, for consideration of primary angiitis of the central nervous system, it is done routinely. And I would say that we see something, be it the meningeal enhancement or the vessel wall enhancement, or even we're doing a lot of patients with giant cell arteritis and superficial temporal arteries. I would say about 3/4 of the time. But I will. I'm not sure whether Bruce is on the lecture or Kyle is on the lecture. If so, please give us your overall experience about black blood imaging and vasculitis. Some of the entities, particularly if they're very small, the small vessel variety, usually we do not see enhancement in the larger medium vessels. Maybe we see the meningeal enhancement. Was diffusion weighted MRI have a role in the diagnosis of vasculitis? Yes, obviously, a lot of times the patient's manifestation is a neurologic deficit for which we're doing diffusion weighted scans. And for example, in patients with PACNS, the most common thing that we're seeing is ischemic injury of different ages on the conventional MRI more so than the black blood imaging. If a patient comes in for an MRI scan for PACNS, we initially do the plain MRI with gadolinium. Maybe we'll get lucky and see in the vessel, but they get a separate vessel wall imaging study at a later date, often with surface coils to look at the vessels in the periphery. So yeah, you vasculitis. Obviously, the risk of vasculitis is thrombotic events, embolic events, and primary vascular events leading to stroke. So we do DWI. Have you seen any vasculitis cases missed at 3T and seen at 17? So I'll answer that kind of obliquely, and that is with regard to multiple sclerosis. So we know that multiple sclerosis is a perivenular disease entity, and we rarely will see the perivenular nature of multiple sclerosis on 3T. But when you do 7T imaging and you see those veins so well, you can see that MS is eccentric around those veins and is a perivenular demyelinating disorder. So I believe that 7T would be very helpful in the evaluation of patients with vasculitides in enabling us to see the enhancement in the vessel wall and those vessel walls, and maybe even some of those entities that I mentioned that may be on the venous side, particularly lupus, particularly sarcoidosis. It may be very useful in that setting. And we do have a 7T scanner, but it's a research scanner that's run by our FM Kirby Center, headed by Peter Benzel. If a 67-year-old with multiple T2 hypointense foci in the subcortical, can we exclude amyloid angiopathy? No, not at all. If we see small microhemorrhages in the periphery, subcortical white matter, whether it's with or without a cortical involvement or lobar hemorrhage, or with or without hemosiderosis, definitely amyloid angiopathy is in the differential diagnosis. The first thing we do is we look at the atherosclerotic risk factors and the EMR and see whether the patient is hypertensive, well controlled, not well controlled, malignant hypertension, because frankly, hypertensive patients are much more common than patients with amyloid angiopathy. So we would still include that as more likely in the differential diagnosis. If you then add a few more hemorrhages in the basal ganglia, thalamus, brainstem, that pushes us even more strongly towards hypertension, as opposed to amyloid angiopathy, where sometimes those deep gray matter structures are spared. Scrolling. For routine intracranial MRIs of the circle of Willis vessels, do you do post-contrast imaging, or do you confine it to cases where vasculopathy is suspected? So we are doing non-contrast MRA for the vast majority of those patients who have circle of Willis MRA. The instances where we will give the contrast are those specifically for vasculopathies, vasculitis cases, and also in some of the cases where we're looking at stented vessels for residual aneurysm. We think that giving the contrast actually helps us see whether stented vessels are patent or not, and whether or not there's little areas of contrast enhancement blebs that you might not see on the non-contrast scan. Certainly for anything out in the periphery of AVMs, et cetera, a lot of times giving the GAD for the peripheral MRA is very helpful. And on the venous side, frankly, I think that doing non-contrast MR venography is worthless. I mean, there's so many examples where we've seen the veins that were thought to be narrowed on the non-contrast MRV just, show normal enhancement and normal caliber on the enhanced MRV. So I would recommend, if you're doing non-contrast MRV, I would just completely eliminate it unless the patient's, GAD allergic. Okay. Our CVS, which is the preferred modality, CTA or MRI with vessel wall imaging? Because the patients usually are manifesting with a thunderclap headache, the differential diagnosis is usually an aneurysm, and an aneurysm that bleeds. So the vast majority of patients are seen in the ED. They get a non-contrast CT to look for subarachnoid hemorrhage because of this severe thunderclap abrupt headache. And in the scanner, they are then lead to CTA. So in my opinion, for the peripheral vessels and for vasospasm in particular, I think CTA is superior to MRA. It shows those peripheral vessels better, in my opinion. Which is more sensitive in temporal arteritis, PET CT or MRI, or better PET MRI? Don't have experience with that. If any of the people in the audience are using PET MRI to look at arteritis, by all means, weigh in here. I don't know whether Elchin's on, the head of nuclear medicine now at Cleveland Clinic's on, but maybe she can give an opinion. Don't have experience with that. Sorry. Is time of flight imaging enough to exclude stenosis? I'm not sure whether you're talking about in the neck or intracranially. Our protocol is to do a non-contrast 3D time of flight through the carotid bifurcation just looking at the bifurcation with non-contrast, and then we do the contrast enhanced MRA of the neck to look at those blood vessels, both at the aortic arch, as well as to relook at the carotid bifurcations. And I usually take whatever is worse between the enhanced bifurcation or the non-enhanced high resolution bifurcation. I usually report the worst looking of it. There's reasons why one would be better than the other, which gets into the techniques of MRA that I don't want to necessarily get into at this point. What is the most sensitive gold standard imaging for the diagnosis of vasculitis? So conventional arteriography is, I would say, is still the gold standard, with the caveat that the vessel wall imaging enhancement sometimes will find areas of inflammation in the blood vessel where it has not manifested as narrowing. So that's sort of the argument for doing black blood imaging, vessel wall imaging, is that sometimes, as with atherosclerotic disease, it's not all that narrowed, but there's a lot going on in the wall, and that's why we want to do it. So I think that there's reasons to do both. Where in which segments is the stenosis located in RCVS? So usually it's out in the peripheral vessels. It's not in the carotid or the proximal vessels. Usually the manifestations that I've seen have been in the, for the example, I showed you the example of the pericallosal artery, the callosal marginal, and the more peripheral of the middle cerebral artery vessels rather than centrally. Which non-contrast MRV techniques do you commonly use, such as time of flight or phase contrast? So as I said, I'm not a big fan of non-contrast MRV, time of flight. If there is a bright clot, remember that time of flight is a T1 weighted sequence. So if you have, for example, superior sagittal sinus thrombosis with methemoglobin, bright clot, when you do your time of flight MRV, it's going to look like it's flowing because the bright clot will be superimposed on flowing blood and will look like it's open. So in those settings is where we use phase contrast MRVnography. When we have the suspicion or we've seen on the pre-MRV a bright signal in the blood vessel, because you're going to mistake it for flowing vessel when in point of fact, it's the methemoglobin of the clot. Do you find ultrasound better useful than the initial modality for temporal arteries workup, or proceed right with the MRI with contrast? Not a person who does ultrasound or interprets ultrasound. Yeah. I'm not sure of the value of ultrasound for vasculitis or temporal arteritis workup. I will defer to probably some of you, the European and Indian and Asian individuals who have a lot more experience with ultrasound of the vasculitis than I do. Sorry, can't answer that. Which sequences do you use for extracranial vessel wall imaging? So I don't want to, I don't want to superimpose over Bruce's area of interest. Just look up Bruce Wasserman and vessel wall imaging, and you will see he has developed over the course of time multiple pulse sequences that have evolved. And again, a lot of them revolve around multiple inversion recovery pulse sequences in order to suppress the flow in the wall, in the lumen, in order to best see the wall. All right, there's some chat stuff. Okay, so some chat questions. I'm willing to run over if people don't mind it. Let me see where the chat goes. Okay. Vasculitis. In your experience, how sensitive and specific is vessel wall imaging in the diagnosis of vasculitis? Any tips on how to improve the specificity? A lot of these all look alike. I'm not sure that, other than the size of the vessel and looking at that nomenclature, whether we're going to be able to say that this represents, you know, um, polyangiitis, granulomatous polyangiitis as opposed to primary CNS vasculitis. So not that specific with regard to the different vasculitides. Big sale, remember to check your thing. How angiocentric lymphoma is different than small vessel vasculitis. The cases that I've seen, the enhancement in lymphoma is much more dramatic. You have much more parenchymal involvement that may also show contrast enhancement in addition to the vascular involvement, as opposed to small vessel vasculitis, where frankly we don't see all that often the central brain involvement. Good event, bring and talk aside. To assess the cerebral venous sinuses, what would you recommend, MRV or CTV? Depending upon where you are, I would not move an ED patient that you're evaluating with CT to move them to MR in order to do the MRV. If you're doing the CT non-contrast and there's a concern for, be it idiopathic intracranial hypertension, just do the CTV in the same setting rather than moving the patient around. And I think that they are pretty much equivalent, CTV and MRV, as long as you're doing contrast enhanced MRV. Don't do the non-contrast. Is angiocentric and intravascular lymphoma different or the same? The same thing. Where do I find stenosis in SVCR? Not sure I know what SVCR stands for. Give me another chance. Is diffusion imaging reliable within an area of microvascular change in the white matter? It's the best thing we have. If you're looking for white matter ischemic injury, it's the best thing we have, so we do it. Are there patients who have white matter disease without DWI findings? Every single day, almost every single 65 and over person. All right, I think that I nailed them all in 11 minutes.
I think you got through like 20 questions in that time period. So that was amazing.
Okay. I am available by email, dusum1@jhu for Johns Hopkins University.edu if you have additional questions. And I do recommend the absolutely wonderful course that Pam Schaefer did on stroke, in which she does cover some of the vasculopathies, and also the beautiful course that Francis Deng does on perfusion imaging and stroke. So absolutely fantastic lecturers, great educators, and probably the next step after this noon conference.
Thanks for that plug on those awesome courses, Dr. Yousem. And thanks for such a great lecture today. We really appreciate you being here.
My pleasure. Happy Thanksgiving to everybody.
And thank you so much for the learners for participating in our noon conference and asking such great questions. You can access the recording of today's conference and all our previous noon conferences by creating a free account. We'll also email out a link later today. Be sure to join us next week on Thursday, December 5th at 12 p.m. Eastern, where Dr. Long Tu will deliver a lecture entitled Strategies to Optimize Workflow Efficiency in Emergency Radiology. You can register for that at mrimonline.com. Follow us on social media for updates on future noon conferences. Thanks again for learning with us and have a great day.